A man or woman over 50 walks into an office with pain, pressure, weakness, or bleeding. They expect answers. Instead, they leave with one word hanging over them: surgery. And the moment that word is spoken, fear takes over. People stop asking better questions. They stop asking what caused the problem. They stop asking whether anything safer was tried first. They stop asking whether the scan truly matches what the body is doing. Many people assume that if surgery was recommended, it must be the only serious option left. In practice, it often isn't. I've seen this happen again and again in my 30 years of practice. Surgery can save lives. It can restore function. It can end years of suffering in the right patient, at the right time, for the right reason. But what concerns me is how often people are pushed toward it before the full picture is clear. If you find videos like this helpful, subscribe and leave a like. I share these warnings so you can recognize the signs early, before they become harder to ignore. And if you're dealing with something similar or have a question, write it in the comments. The early mistake is simple. People hear, "We found something," and they assume we must remove it. But the body does not work that way. A scan can show a real problem on paper, but not the true source of your symptoms. A test can look alarming, while the condition may still respond to time, therapy, medication, weight loss, rehabilitation, injections, or a more careful workup. I've seen strong, independent people agree to operations they did not fully understand because they were tired, scared, and in pain. That is exactly when people are most likely to make a decision they later regret. Just last month, a patient came to me with this exact issue. She had been told she needed a procedure quickly. She was frightened. But when we slowed down, reviewed her symptoms, and looked at what had and had not been tried, it became clear that surgery was not the first step. What she needed first was a fuller evaluation and a better plan. That is where the danger lies, not in surgery itself, in skipping the steps that should come before it. In this video, I want to walk you through 5 surgeries adults over 50 should question before saying yes, not automatically refuse. Question. Slow down. Understand. The first is spine surgery for back pain. This is one of the most common patterns I've seen in older adults. Low back pain starts, then maybe leg pain, maybe numbness. An MRI is ordered. The report shows a disc bulge, narrowing, or degeneration, and suddenly the conversation shifts from pain to surgery. Here is what many people over 50 are never told clearly enough. MRI findings become more common with age, even in people who have little or no pain. In other words, what appears on the scan is not always the reason you hurt. That matters. Many people assume, if the MRI looks bad, my back must need surgery. But what I've seen in practice is that many patients improve with the right combination of physical therapy, targeted exercise, time, anti-inflammatory treatment, posture correction, weight management, injections, or a more precise diagnosis. Now, there are times when spine surgery should move quickly. Progressive weakness, loss of bowel or bladder control, severe nerve compression with worsening function. Those are different conversations. But most people are not dealing with a true surgical emergency. They are dealing with pain, stiffness, sciatica, and fear. And fear often pushes them toward the fastest sounding option. What makes this dangerous is that surgery on the spine is not a small decision. Recovery time, scar tissue, and the risk of future problems are all real. Once the body has been operated on, you cannot go back to untouched tissue. That is why, before saying yes, I would want to know, was a full conservative plan tried? Was the diagnosis carefully matched to the symptoms? Is there true neurological decline or mainly pain? And the next surgery is one many people accept out of embarrassment rather than urgency. That is hemorrhoid surgery. Patients like you come to me with this exact issue more often than you might think. Bleeding, burning, swelling, pain with bowel movements. And because it is such an uncomfortable subject, many people just want it fixed as fast as possible. That is understandable. But this is where many people make a serious mistake. Hemorrhoids can absolutely become severe enough to require a procedure. Persistent bleeding, severe pain, prolapse, or repeated failure of conservative care can all make surgery reasonable. But not every case should move there first. Many people assume hemorrhoids are simply a local problem. What I've seen again and again is that they are often made worse by chronic constipation, straining, low fiber intake, dehydration, long hours of sitting, weight gain, and poor bowel habits. If nobody has addressed those factors, then surgery may treat the visible result without reducing the pressure that helped create it. What concerns me is how often people are offered a procedure before they are offered a real plan. Has fiber been increased? Has hydration improved? Has constipation been treated? Has prolonged straining been addressed? Has the bleeding been properly evaluated so something more serious is not missed? And the next one is especially important for women over 50. Pelvic organ prolapse surgery. At first it may seem small, a feeling of pressure, heaviness, a bulge, discomfort after standing, urinary leakage. Many women dismiss it for months or years because they are embarrassed or assume it is just part of getting older. Many people assume surgery is the automatic answer once prolapse is found. In practice, early and moderate prolapse may respond well to pelvic floor physical therapy, weight reduction, bowel habit improvement, pessary use, and better management of straining or chronic coughing. This is exactly the kind of symptom that fools people into waiting too long on one hand or agreeing too quickly on the other. The question is not whether prolapse is real. It is. The question is how advanced it is, how much it affects daily life, and what has been tried first. I've seen this brushed off as normal aging. I've also seen it sent to surgery too early, before conservative options were properly used. What makes this dangerous is that surgery does not always end the story. There can still be recurrence, discomfort, and ongoing pelvic floor weakness if the underlying support system was never improved. So before saying yes, I would want a woman over 50 to know her stage, understand her options, and ask whether pelvic floor therapy was fully explored. Now, the next surgery is often sold as a simple fix for a very common frustration: varicose vein procedures. When people see bulging veins, aching legs, heaviness, or swelling, they often want them removed quickly, and sometimes that is appropriate. If there is significant pain, skin changes, bleeding, or clear circulation problems, intervention can help, but not every visible vein needs a procedure. Many people think varicose vein treatment is only about appearance. Sometimes it is partly cosmetic. Sometimes it is medical. The difference matters. What I've seen in practice is that some people are moved toward procedures before they have consistently used compression stockings, increased walking, managed weight, reduced prolonged standing, or had a careful vascular evaluation. That is where I would be careful. If the issue is mild, the symptoms are manageable, and the deeper circulation problem has not been fully assessed, then fixing the vein may not be the first step. And this is where many people make the biggest mistake. They treat the procedure as the plan when it should only be one part of the plan. And the next surgery is one many adults over 50 accept because the pain slowly wears them down: knee arthroscopy, or knee procedures for degenerative wear and tear pain. Over the years, I've learned that the body usually whispers before it screams. And the knee is one place where those whispers are often misunderstood. A man in his late 50s or early 60s develops knee pain. Maybe some clicking, maybe swelling, maybe stiffness getting out of a chair. An MRI shows a meniscus tear. The word tear sounds serious. It sounds like something must be fixed. But many adults over 50 have degenerative meniscal changes along with arthritis. In those cases, the scan finding may sound dramatic, but surgery is not always the answer. Many people assume that if there is a tear, it has to be repaired. What concerns me is how often that idea sends people towards surgery before physical therapy, weight loss, strength training, anti-inflammatory treatment, injections, bracing, or activity changes have had a fair chance. This is not to say knee surgery is never helpful. Locked knees, traumatic injuries, major instability, advanced joint damage, and severe loss of function can all justify surgery. But for common age-related knee pain, the best first answer is often not a scope. What makes this dangerous is simple. If the real problem is overall joint degeneration, weakness, inflammation, and poor mechanics, then cleaning up one part of the knee may not give the long-term result the patient expected. And the fifth surgery adults over 50 should question before saying yes is gallbladder removal for borderline or unclear symptoms. Now, this one needs care because gallbladder surgery can be absolutely necessary. Repeated attacks, clear gallstones with classic symptoms, infection, pancreatitis, and complications should never be minimized. But this is one of those areas where I've seen patients push toward surgery after vague digestive complaints that were never fully sorted out: bloating after meals, nausea once in a while, upper abdominal discomfort that does not clearly fit the pattern. Sometimes imaging shows stones or sludge, and the assumption becomes, that must be the cause. Sometimes it is. Sometimes it is not. Adults over 50 often have more than one thing happening at once: reflux, fatty liver, medication side effects, food intolerance, Slow digestion. If the symptom picture is unclear, removing the gallbladder may not solve what the person was actually feeling. I've seen this happen again and again. The operation goes well, but the original discomfort remains because the gallbladder was not the full story. That is why before saying yes, I would ask, are the symptoms classic? Do the test results truly match the symptoms? Has a full digestive evaluation been done? Is there true urgency or simply uncertainty? Let me bring this together in the simplest way I can. If you are over 50 and surgery has been recommended, do not panic. But do not surrender your judgment either. Slow the conversation down. Ask what happens if you wait a little. Ask what non-surgical treatments are still reasonable. Ask what red flags would make surgery more urgent. Ask what the expected benefit really is. Ask what percentage of patients improve without the operation. Ask what the risks are if you do it now and what the risks are if you do not. And most importantly, ask one question many people forget to ask. What exactly are we treating? My symptoms, my scan, or both? That question changes everything. Because the body rarely starts with a crisis. More often it starts with a pattern. Pain that lingers, pressure that returns, bleeding that repeats, weakness that slowly gets worse. The people who do best are usually not the ones who move the fastest. They are the ones who understand what is happening before they agree to something permanent. In my experience, the best surgery is the one that is clearly needed, carefully timed, and chosen with both eyes open. And the operations people regret most are often not the ones that went badly. They are the ones they never truly needed in the first place. If this video helped you, subscribe for more guidance like this. And if you've noticed any of these signs yourself, or if you still have questions, share it in the comments.